Hi, thank you for asking me to talk on your endometriosis masterclass about ultrasound imaging for endometriosis. My name is Suzanne Johnson. In this talk, I'd like to dispel a myth that's, I think, at least partly responsible for the 8-year diagnostic delay of endometriosis. Talk about the idea, the language, and the system with the steps that they've recommended. Perform a live scan, not really live, and some resources. The myth is you cannot see endometriosis on ultrasound. It's simply not true. This excellent paper from last year, published by Matthew Leonardi and his co-authors, demonstrated that ultrasound has a very high specificity and sensitivity for ovarian and deep endometriosis and pouch of Douglas obliteration. It does require a high level of training, and having done that, the sensitivity and specificity for ovarian and deep is very high, but superficial endometriosis is very difficult to see on ultrasound. In this paper, they showed this beautiful image showing what a nodule of deep endometriosis would look like on speculum examination, at laparoscopy and on ultrasound, and I think you simply can't miss it on ultrasound if you know where to look. So ultrasound and endometriosis, normally we do a routine pelvic ultrasound that looks at the uterus and ovaries mainly, but we also need to look for deep endometriosis, mobility and site-specific tenderness. The IDEA group gave us a language to use and also a system with 4 steps that could be performed in any order, and I'll show you the order I do it in. Language really matters, and this from the IDEA group is if you draw a line through the internal os, you see the torus just behind there, draw a line below the level of the cervix. Below that red line is the rectovaginal septum. Above that white line is red line is the posterior vaginal fornix. The pouch of Douglas is just there, and then below the green line is lower rectum, above the green line upper rectum, so that's the line going through the torus, and the bowel that's level with the uterine fundus is called sigmoid. In the posterior compartment then, the area behind the uterus, common locations for deep endometriosis would be in the posterior vaginal fornix, at the torus, in the lower rectum, in the upper rectum, and sometimes everything adhering together with frozen pelvis. Just thinking about the bladder, in the anterior compartment, there's the trigone in yellow, the base in pink, dome in red, and then extraperitoneal in white. How do I do the IDEA scan? I start with a systematic routine pelvic ultrasound looking for features of endometriosis like adenomyosis, ovarian endometrioma and ovarian adhesions. I usually ask the patient to have an empty bladder, but I don't use routine bowel prep. You can offer your patient a drink of water as they come in, as it helps to fill the bladder up for the end of the scan nicely. Be very gentle. The gentler you are, the better you'll see, and the nicer it is for the patient, obviously. Patient's bottom should be overhanging the edge of a couch. I never ever use a wedge, and then use knee supports or have feet on a chair. And then I'll say, let your knees go floppy, and I'll say this repeatedly as it really helps you to look better and for the scan to be a lot less tender. And then slowly insert the probe with plenty of lubricant on the outside of the probe, and then perform a systematic pelvic scan. This is my scanning orientation, and that would be the position of the uterus if it's anteverted. And remember that whatever you see on ultrasound is the other way round to seen at laparoscopy. Uterine position briefly, it's an anteverted uterus toward the bladder, a retroverted uterus toward the feet, an anteverted but retroflexed uterus, especially relevant here, and an axial uterus. So, starting the systematic pelvic scan, looking for features of endometriosis. This uterus here is anteverted but retroflexed, and it's retroflexed because it's pulled backwards by adhesions. This was published in 2015 by Nadine Di Donato. Adenomyosis as classified by the Musa group. Lots of different features of adenomyosis, again a close sister condition of endometriosis. In this case, you can see an anteverted uterus and the longitudinal plane going from side to side. This is a bulky globular uterus with a very indistinct endomyometrial junction, little myometrial cyst, there's the junction, and this fan-shaped shadowing. So it's typical of adenomyosis. Sometimes adenomyosis looks different, and you can see these islands of endometrium in the myometrium. And on 3D, you can see a very irregular endomyometrial junction all the way around. Often people will actually see an ovary being low and not know the relevance of this. And if you see a low ovary, you have to think of adhesions, and the transverse view is very valuable here. This is the internal os, there's the torus, so this ovary is sitting at the level of the torus. If you go transverse in that plane, patient's right, patient's left, this is the torus. Here you can see this white line is the uterosacral ligament. So it's sitting on the ligament and it's probably adherent to it. You'd need to do a little video for that. Next thing to look for is ovarian endometriomas with or without adhesions. And in this case, again, you can see a unilocular cyst with ground glass echogenicity cyst contents. It's located at the level of the torus and uterosacral ligaments again. And if we go transverse on that, patient's right, patient's left, you can see that that ovary is adherent to the uterus. Compare that to the other ovary where you've got a nice cantilevering of the ovary with some very gentle probe pressure. Again, in the transverse plane, looking patient's right, patient's left, this is the torus, this is where the uterosacral ligaments insert. And you've got bilateral endometriomas. You can have anechoic endometriomas. They're kissing and they're adherent to the back of the uterus. The important thing is, don't stop there, is ovarian endometriomas are rarely isolated, as in this paper by Katerina Exkustos. The sliding sign next. This was published in 2013, and you just need to know where to put your probe. In an anteverted uterus, if this is the anteverted uterus, if this is the anterior fornix, if you put your probe in the anterior fornix, this is the view you'll get. You can see the cervix, and when you press very, very gently with the probe, that's all I do, very, very gentle probing with the probe, you can then see movement behind the cervix. If you put your probe in the posterior fornix, you now can't see the cervix, you've pushed that out of the way, but you can see bowel nodules and adhesions. But we want to do the sliding sign, so it needs to go into the anterior fornix in an anteverted uterus. So this is what that would look like. Anteverted uterus, probe in the anterior fornix, there's movement. The bowel behind the womb and the uterus are moving in different directions, so this is a normal sliding sign. So this is an abnormal sliding sign. You can see there's movement, but everything moves together. Where to put your probe in a retroverted uterus? If you put the probe in the anterior fornix, you can see the cervix, but it's quite difficult to judge mobility at the back of the uterus. This is the torus, and this is where we need to see mobility behind the uterus. So putting it in the posterior fornix, you can't see the cervix because it's pushed out of the way, but you can now see the sliding sign of uterus against bowel and look for bowel nodules and adhesions. So in a retroverted uterus, we need to put the probe in the posterior cervix, which is where it tends to end up anyway. And this is a normal sliding sign in a retroverted uterus. Again, we've got the torus at the back there. We've got a lovely normal peritoneal reflection, a little bit of free fluid, and that bowel is moving freely against the posterior uterine wall. So normal sliding sign. Here though, in this retroverted uterus, patient's feet are here, you can see that there's dense adhesions all across the back of the uterus, and this is an abnormal sliding sign. So far so good. So what's the problem with diagnosing endometriosis? I think it's through training. If you only ever look at the ceiling, you are never going to see the rock on the floor. If you only look at the uterus and bladder, you are never going to see abnormalities in the posterior compartment. So let's look for nodules of deep endometriosis, where to look and how to look and what do they look like. You can have deep endometriosis in the posterior compartment and in the anterior compartment. So starting with the posterior compartment, I just divided into 3 layers. It's easier: vagina, ligaments, bowel. Vagina. This is a normal posterior vaginal fornix. So this is the cervix, external os, cervical canal, internal os. And you can see the outline of the posterior lip of the cervix nicely because there's a little bit of discharge there. At this level, we've got the internal os and therefore the torus there. And I'm just going to, in this longitudinal plane, slightly go from side to side, showing you a normal posterior fornix. So what does deep endometriosis look like in this fornix? I'm pushing the cervix out of the way, going into the posterior fornix. That's normal vagina, normal. And here is this nodule of deep endometriosis in the posterior vaginal wall. So it's this nodule that we're looking for. And of course on speculum examination would look like that. Ligaments, torus and uterosacral ligaments. So in a posterior view of the uterus, torus and the uterosacral ligaments. Pouch of Douglas just there. Most of the deep endometriosis nodules are located at the torus. So on ultrasound is an incredibly important bit of anatomy. So what does it look like on ultrasound? We're going to look at the longitudinal view of the internal os, looking at the torus, and then I'm going to rotate my probe to transverse. So I'll start the video. I'm just going longitudinal on the internal os, and now I'm at the torus. And so the line this way, little fine white line, is one uterosacral ligament, that's the other. And you can see they're very difficult to see. If they're normal, then they're very difficult to see. If they're not normal, it's not hard at all. So that's normal uterosacral ligaments. So normal looked like that in the longitudinal view and like that in the transverse view. But if you've got Uretero-Vesical fibrosis at the torus, extending maybe into the ligaments, you get this whiteness. And then the nodule of deep endometriosis is easily visible because it's this irregular dark area, hypoechoic. And you can see when I've rotated on that point, we've got the torus here. I've got very thick uterosacral ligaments. Another interesting thing to think about is that we've looked at the torus now and at the ligaments in the view I just said, but when you've got the TV probe in the vagina, which is just in front of this tissue here, of course, you could stretch the uterosacral ligament over the top of your probe. So this is what that would look like. If I've got my probe in the vagina, this is a retroverted uterus. The internal os is here, the torus is here. This is a nice bit of free fluid. I'll move the probe laterally a little bit, and then suddenly you'll see a uterosacral ligament there. That's the uterosacral ligament. With a bit of pressure, I'm applying it over the TV probe. Little bit of pressure from the probe, and here I'm letting go again. And what you can see is that we've got the vagina and the posterior fornix, peritoneum, and the uterosacral ligament. And when you press very gently, they all blend into one white layer overlying the tip of the probe. So that's a normal uterosacral ligament. So different ways of looking at the same thing. So a nodule of deep endometriosis in these thick uterosacral ligaments would look like this. I'm in the posterior fornix, the cervix is over that way. Here is vagina. This white is the Uretero-Vesical fibrosis, or maybe in the uterosacral ligament. And then I've got my focus here, and I've got my frequency as high as it will go into the highest range of harmonics. And that's when suddenly you'll see this nodule of deep endometriosis at the tip of your probe. So that was vagina and ligaments. Next, bowel. So to look at bowel nodules, you really need to go through the posterior fornix, because this is where you'll be closer to bowel. This is bowel here. You will be able to see nodules and adhesions if they're there, if you look carefully. So how do we get from the anterior fornix to the posterior fornix in an anteverted uterus? I'll show you how. We need to move it from the anterior to the posterior fornix. So here you can see that I'm just going to very gently withdraw the probe a little bit, angle it backward toward the sacrum, and stretching the vagina over the end of my probe. And here I am in the posterior fornix, cervix is there. A little bit of free fluid, and then I'm going to withdraw my probe again in a minute, and you'll see a lovely normal peritoneal reflection there, and here I am back in the anterior fornix. So when you're in the posterior fornix, you can look at bowel, and people say, I don't know where I am when I'm in the posterior fornix, but you do, because you are right here. The uterus and everything's been moved off to the side. So what can you see? You can see vagina, you can see peritoneum, maybe with the uterosacral ligaments, depending on where you are, some free fluid, and then this is the bowel. And it's composed of many different layers. So the outer white serosa, then a triple layer of muscularis, the dark white dark layer. The outer layer is longitudinal muscle fibers, some fibrous tissue, and the inner circular fibers. Muscularis, the most important layer here. Then we've got submucosa and mucosa together, submucosa and mucosa together. Then again, we've got muscularis and serosa. So this is the anterior wall, posterior wall, and that's the lumen. The muscularis layer is the most important layer. It's easily seen because it's a triple layer. And when it's involved with endometriosis, it looks like this. It becomes a very dark hypoechoic shape outlined by white tissue. So thick muscularis layer, and you can see how I do this, how I find this layer in the next slide. You withdraw the probe a little bit below the cervix, and then you look for that layer, which you can see it just there. There's serosa, there's the muscularis, and then keep your eye on that layer as you very gently introduce the probe. You can see I'm following it, and you can see I'm tracking it through the second rectal curve. You can see that's all muscularis, and I'm going to adjust my position a little bit and keep going. And you can often track muscularis up to the uterine fundus, but not always. So tracking that layer through the posterior fornix, there's the second rectal curve, and you can see that you can track muscularis. Sometimes then you will come across an abnormal bit of muscularis, and it will have normal muscularis going in and out of it, and it is highlighted by very bright white, which is the submucosa and mucosa. Normal muscularis on the other side, the posterior wall, is never affected by endometriosis, and you can see the disparity in the thickness of the bowel wall. Colour, it doesn't really have much vascularity. If it did, then you need to think of other pathology. So just looking at this bowel nodule, again, in longitudinal plane, just going slightly from side to side, you can see normal muscularis going in and out of it, and you can see that this is a nodule of very disrupted muscularis, very disrupted and thick. What you can also see in this slide is that the posterior vaginal fornix is normal, and you've got some fibrosis here with nodules of deep endometriosis in it. And sometimes you've got all three layers affected, as in this example, got very thick posterior vaginal fornix, retrocervical fibrosis, deep endo within it, and then also this bowel nodule. The bowel nodule just there. You can see that they're all attached to each other. This is some more deep endometriosis. So in this example, you've got vaginal, ligaments and bowel all affected. So that would be a rectovaginal nodule. Then you can say where in the bowel is this nodule. So this one is in the lower rectum. We're below the level of the torus. You can track muscularis there, and almost immediately there's this nodule. We're nowhere near the internal os. So this is lower rectum, and you can see it, of course, again there. This one involves the lower and the upper, because the line through the internal os to the torus, point of attachment of the uterosacral ligaments, defines lower rectum and upper rectum. And so in this video clip you can see, again, tract muscularis as you enter the vagina, and then there's this big plaque that goes right across the level of the torus. This person had a very large upper rectum and sigmoid plaque of endometriosis. You can see it starts below the level of the fundus, but it goes up and over. There's a big ovarian endometrioma there as well. So this one goes up and over. Sometimes you have more than one bowel nodule. If you have one, you need to look everywhere else. So this one is a very large stenosing retrocervical nodule. It's in the torus, it's in the uterosacral ligaments and the lower rectum. We're below the level of the torus. Then as I went higher, near the left ovary in the sigmoid colon, I found 2 more nodules of deep endometriosis. Important to examine the whole bowel if you can. There's one and there's the other. You can see the normal muscularis going in between them. And we look at the angle, so as in this nodule, you can see that it's in the upper rectum. The torus is about there, so this is upper rectum, and it's relatively flat, 180 degrees, and it occupies less than half of the bowel diameter. This is transverse view of this, so this is right, this is left, let's say, and this is occupying less than half of the diameter of the bowel. When you have a curved bowel nodule, we also here would be thinking about stenosis. This is how you measure the bowel nodule, and this is the angle between them. That's the depth, and that's the width. So a retracted mushroom nodule, if the angle is less than 90, we're going to think of bowel stenosis. If more than half the bowel circumference is affected, and if the AP diameter is more than a centimetre. Then we're always asked, what's the distance to the anal verge? And this book is superb. In chapter 12, the authors describe that the bowel curves. There's the first rectal curve at 3 centimetres from the border, the second one at 8 centimetres. The peritoneal reflection, if it's present, is at 7, the same as the lower edge of the cervix, and then the torus is at 8 to 10 centimetres. The problem with working out where your bowel nodule is in relationship to these other landmarks is that they are variable. If you have an obliterated patch of Douglas, you can't use these quite often. So what I tend to do is I say, is it above the level of the torus or is it below the level of the torus? And then try to estimate the distance to the anal verge in a different way. And this is how I've been doing it. I've got an extended view transvaginal probe. As I'm inserting it, I'm tracking muscularis. There is the bowel nodule, and then I measure that. I measure it to the point where I can't see muscularis anymore, and then I add 3 centimetres for the first rectal curve. So then we've got a distance to the anal verge of 83 millimetres. The other thing you can do is you can do 3D and 4D. 3D can be really quite useful if the patient's very tender and you can't get a good measurement for length or width for that matter. And also you can really judge submucosal involvement, which is again a strong marker for stenosis. That was the posterior compartment. Next, the anterior compartment, the bladder and ureter. Again, bladder, we've got trigone, base, dome, and extraperitoneal. And it is the base and the dome that are most commonly affected by deep endometriosis. Again, a disruption of the muscularis layer, but it's harder to demonstrate that layer in the normal. Just showing showing some videos of normal. This is urethra, bladder, uterus, and the lower left ureter, and I'm going to go from left to right across the trigone, showing both ureters. So that's where we're starting. That's the ureter coming into the bladder. I'm going across. This is the trigone going out the other way, and there is the beginning of the other ureter just there. So again, ureter coming into the bladder, going across the trigone, out the other way, and then there is your other ureter. And if you rotate your probe medially a little bit as you are going across in the longitudinal plane, you'll be able to demonstrate both ureters. You have to be medial both sides. This is how you can confirm that something really is a ureter rather than a vessel, let's say. You get vermiculation, and this is normal. This is a transverse view of the Uretero-Vesical junction. I've got trigone in the centre, the right ureter and the left ureter. So deep endometriosis in the bladder, it's a disruption of the muscularis layer, and here you've got a really bad, huge nodule. And this nodule is a bit more typical, I would say. So again, deep endometriosis in the muscularis layer. You can then measure the distance from that to the vesico-ureteric junction. So where do we look for ureteric DE? We look at it at the bladder, at the junction, but also at the internal os. And so ureteric DE is mainly, of course, external compression by fibrosis. And if you extend your field of view To look above the ovary, you might see that this ovary is fibrotic to the ureter. There's a small hydroureter above it. Patients' feet are that way. And so if you can see the ureters or not, you need to look at the kidneys. This is a different case of gross hydronephrosis in a patient with endometriosis. And so we always check the kidneys in women with any endo. Soft markers, I do this at the end because if I now need to know where is something particularly tender, if you do this too early, then sometimes the patient is unable to tolerate the rest of the scan. So what I do is I go around uterus, ovaries, pouch of Douglas again, saying, is this sore, is this sore? And I can, again, just judge pelvic mobility that little bit better at this time. So just to demonstrate all this in a live scan, it's not really live, of course. This patient was 39, had severe dysmenorrhea, had bad menorrhagia, and then really awful constipation, 6 times a day, just small pellets, no children, no surgery, CTKB was normal, and she had a raised CA125. So look as you insert the probe, and then almost immediately as I got to the cervix, there's resistance. This is a frozen pelvis, so that took about 1 second. Then we're going to be disciplined, do it in a systematic way, so looking at the uterus, also looking at the cervix importantly, and here we've noticed some minor diffuse adenomyosis, and then also a little bit of what used to be called superficial adenomyosis, but it's probably a little bit of deep endometriosis actually. The endometrium is thin on day 1, the endomyometrial junction's not all that clear. And then looking at our ovaries, they're probably bilateral small anechoic endometriomas. They are low in the pelvis, but not kissing. Here I've rotated on the torus, and you can see that both ovaries are adherent to the uterosacral ligaments. I would have proved that by some very gentle sliding sign. So what have we got so far? We've got that uterus with a bit of adenomyosis, a nodule of superficial adenomyosis and the anteriorly, just there. We've got these bilateral low ovaries with endometriomas, and then something else caught our eye. And it was a bowel nodule. So we're looking at the area of the torus now, but we'll start with the bowel nodule given that it's shouting at us. Here I am measuring the length of it. I like to measure it along the length of bowel that's affected, and the depth doing only the disruptive muscularis. The width, that's the width of it. I've just rotated on that nodule, and then that is the bowel width. So you can see it's nearly 50%. Where is it? The level, it is, there's the torus again. That's where the bladder sort of adheres to the uterus, internal os torus. You can see this is lower rectum and upper rectum. And the angle, if you measure it that way, is more than 90 degrees. But it does look stenosing if you look at the bowel diameter here and just above the lesion, it's halved. Where was it? As I was inserting the probe using extended view, this was 110 millimeters. So this is the beginning of the nodule. Patient's head is here. So here I tracked muscularis again, and then you can't track it anymore there. So that's the first anal curve, so 110 millimeters. So just looking again at this bowel nodule, looking for all the other bits of anatomy nearby, you can see that there's ureterocervical fibrosis, and then you see this very faint, dark, deep endometriosis just there. You can also see that the posterior vaginal fornix is normal. So there's that deep endometriosis at the torus extending into the uterosacral ligaments like that. And the vagina looks normal. So the overview was of ovarian endometrioma, ureterocervical fibrosis, bowel nodule, deep endometriosis, and we're in the anterior fornix again. So a frozen pelvis with ureterocervical fibrosis. Then don't forget the bladder. By the end of the scan, most people have some urine in the bladder. You don't have to have a lot, a bit more would have been nice here. I can see that there's that nodule of adenomyosis stroke deep endometriosis with a lot of fibrosis and adhesions around it, and if you hunt, you'll find some deep endometriosis to one side and some deep endometriosis toward the other. And at the end of the scan, I like to draw patients a cartoon. People find it easy to understand what I'm trying to explain to them. So here would be that nodule of superficial adenomyosis, the deep endometriosis associated with it within fibrosis. At the level of the torus, we had the nodule of deep endometriosis plaque. There's the ovarian endometrioma adherent just close to it. This is that bowel nodule that spans across the level of the torus, so it's lower and upper rectum, and then these dense adhesions, so the peritoneum is only to there. Then I like to say in the longitudinal view, coronal really, there's the level of the torus, the ovaries are both adherent to it, that's the deep endometriosis. And I think it helps to explain that you cannot get this view at laparoscopy. So in my report, severe endometriosis, minor diffuse adeno, some superficial adeno with deep endo in the vesical uterine pouch with adhesions, bilateral small endometriomas adherent to the uterosacral ligaments not kissing, large plaque of DE in the torus and USLs, a large stenosing bowel lesion where it is, and an obliterated pouch of Douglas, a frozen pelvis. So these are some great resources, some online stuff, this wonderful book. This is a great website by Sophie Peasons with lots of examples of how to diagnose endometriosis. And then, of course, on my website too, there are lots of step-by-step videos. Patient voices, so important. This book is unbelievably sad, and the Private Parts by Eleanor Thom contains lots of really good information for patients with endometriosis, and I think we should all be handing these out freely if possible. So in conclusion, you can see endometriosis on ultrasound, but a lot more training will be required before it can be done by everyone. Transvaginal ultrasound is great for planning surgery, and expert transvaginal ultrasound is great for understanding patients' pain. Seeing is believing. Thank you.